Well, thank you for the warm welcome. I want to thank Jessica, Dr. Dale for this invitation and the opportunity to share some of our work. And yes, I told everybody back in Gainesville was jealous that I was getting to come see the sea turtles again. And we had a wonderful visit not too long ago, a few months back, with our Cancer Center Director and Associate Director of the Cancer Center. And I've really been excited and impressed about the work that's being done here and honestly how we see the opportunities to connect and to collaborate and even further advance our understanding of cancer biology and cancer treatments. So the topic I'm going to go through this evening is to try to give an overview of what's a pretty broad field of science called cancer immunotherapy, and to focus a little bit on the approaches that we are taking at the University of Florida to try to develop effective treatments for a pretty challenging disease of malignant brain cancers. I do have a few disclosures. So as mentioned, I do have some patents that are related to this field and that have been licensed into pharma. They will not be the focus of this presentation, but I suppose it's worth disclosing that I have those interests in the field in general. The outline, I'll touch a little bit on cancer immunotherapy and how did we get to where we are in the current field. I think many of you probably have heard and probably seen commercials about cancer immunotherapy, maybe have heard some of the lay press coverage that the field has received over the past couple of years. Back in 2013, a Science journal cited cancer immunotherapy as the breakthrough of the year in their issue that they do in December of every year, where they look at all the different areas of science and try to highlight what they believe has been the largest incremental or I guess breakthrough accomplishments in that year. And so it's, over the last, say, 5 to 6 years or so, has been a field that's received a lot of attention. But in fact, it's like most things in science and advancements that we make in medicine, it's really been built on a foundation of knowledge that's been built over many, many, many decades. I do tell the story a little while ago. I was at a national meeting and had a chance to talk to a medical student, a young medical student who was interested in research. And she asked me how long had I been involved in looking at cancer immunotherapy. And I said, I started graduate school in 1995, and my graduate work was actually in cancer immunology. And she just said, wow, you've been involved since the very beginning. And I said, no, the very beginning is about the 1800s, as I'll show you, but I appreciated her perspective. We'll talk about then, how to apply some of the knowledge that's been gained in the field and how that is being applied in tackling the challenge of treating brain cancer. And then highlight some of the difficulties, but also future directions that we face in trying to bring this modality into being an effective form of treatment for patients. So this is a timeline, really, that dates back that highlights some of the accomplishments in the field of cancer immunotherapy. I'm not going to go through this in detail, but I think it's worth noting. This slide is taken of William Coley, who was a surgeon who in the late 1800s actually observed or actually read about initially a patient who had undergone surgery for a colorectal cancer. Post-operatively, that patient ended up getting an infection, had a bacterial infection of the surgical wound, and subsequent to that, the patient's remaining tumor actually disappeared during the course of that infection. And he hypothesized that perhaps the immune response to that bacterial infection had actually also awakened an immune response to the patient's cancer. And he really began exploring this idea of immunizing or trying to stimulate an immune response in patients. So he is often credited with sort of the earliest interventions of cancer immunotherapy, where he started purposefully infecting patients actually who had cancer to try to induce this type of immunologic response. Those studies back then were not well controlled, and there were some anecdotal observations. But interestingly, while that never really caught on as a standard modality for treatment, there are actually cancers today, a particular type of bladder cancer, that is actually treated by using heat-killed mycobacteria that's injected into the tumors, and a component of the immune response against that essentially indolent infection into the tumor microenvironment does actually lead to the regression of those tumors in many cases. So in some ways, more than 100 years later, at least that concept has been evolved for a limited number of cancers. About 80 years later, our understanding of the immunology behind the immune response to cancer really took a pretty significant leap forward, and that was in the 1970s. by investigator Ralph Steinman and his colleagues at the Rockefeller University, discovered a cell type in the body that's present at very trace amounts called dendritic cells. But his discovery led to the understanding that our immune response against infections and also against cancers is actually controlled, or you could envision centralized, through this very small population of cells called dendritic cells. And these are, you can think of them as almost the generals of the immune army that actually tell your immune system what to attack and what to ignore. And over many, many years, it's become understood that any effective immunologic response, whether it's against a virus, a bacteria, or a cancer cell, requires these cells called dendritic cells to instruct the immune system to recognize that entity as something dangerous to the host, and to also lead a very specific and coordinated attack to eliminate either that pathogen or that tumor cell from the body. And so the discovery of these dendritic cells and the understanding of their central role in the immune response really led to much more specific approaches in how to try to engage the immune system to fight cancer. In fact, in 2010, so that would be now almost 30 years, a little more, close to 30 years later, the first FDA-approved cancer immunotherapy was actually published in the New England Journal of Medicine. This was for metastatic prostate cancer. I will not even attempt to pronounce that name, but its a trade name or laid name is Provenge. But this involved actually harvesting a patient's own blood and exposing these dendritic cells that are isolated from their peripheral blood to a protein that's actually overexpressed at about 70 to 80% of prostate cancer cells. They would mix the patient's own dendritic cells with this tumor-associated antigen. They also provide a cytokine that leads to the activation of those dendritic cells. And then these cells are returned back to the patient intravenously, now loaded with essentially a copy of this antigen or multiple copies of this antigen that's expressed in their own tumor. And these cells essentially lead to the induction then of an immune response now that can mediate some regression or control over that prostate cancer. And so this was a benchmark in the field. It's not curative in all patients, but it did show to extend survival in patients with advanced metastatic cancer and became the first FDA-approved treatment that actually uses a patient's own immune system to attack their cancers. If we look at brain cancers and some of the challenges we face in trying to develop effective treatments for patients with brain malignancies, one of the things that we deal with is obviously the complexity of the central nervous system and its central role in controlling pretty much all of our functions. There are many different cell types in the brain and many different types of brain tumors that can arise, over 100 different types of brain tumors that a person can develop. Unfortunately, when we look at brain cancer as a whole, although it's not the most common cancer, deaths from malignant brain tumors actually exceed many cancers that we hear more often about, such as melanoma, renal cell carcinoma, or Hodgkin's lymphomas. The treatments for brain cancer typically involve maximum surgical resection, radiation therapy for invasive malignant brain tumors, and oftentimes after that, systemic chemotherapies. And despite this very intensive multimodality regimen, brain cancers still remain one of the most refractory tumors that we encounter in the clinical setting. If you look at where these tumors arise, obviously there are central functions that our brain is critically important for. And unfortunately, both the development of these tumors and sometimes the standard treatments that we need to use to try to control tumor growth leads to pretty profound neurologic impairment or deficits in patients. This is often particularly true in children with developing nervous systems, where the radiation treatments and the other modalities that we use unfortunately have pretty significant side effects against the normal CNS tissue. And so when we look at the treatment that's delivered for brain cancer, it is actually the most expensive therapy that we deliver in the United States today when you adjust it for the quality of life years saved. So when we look at the extension of survival compared to the intensity of the treatments, this is really a disease where there's a huge need for an improvement in treatment options and treatment outcomes for patients. In adult patients, the most common type of brain tumor, malignant brain tumor, is a tumor called glioblastoma. It is a grade 4 glioma, meaning it is most commonly diagnosed as an advanced and an aggressive cancer. This affects about 12 to 13,000 adults per year in the United States. And as I mentioned, despite this multimodality therapies, the median survival for this disease is about 15 to 18 months from diagnosis. There's quite a big spread between that. That's just median, but it does highlight the need for a significant improvement in outcomes. And the 5-year survival rates for this disease has been pretty refractory over the last few decades. And so we have really tried to ask the central question, which is there a potential role for the immune system in fighting brain tumors? Many of you may have heard the concept of immune privilege, or CNS, what we call CNS immune privilege, which is the concept really that the immune system perhaps ignores the brain or is not very effective at fighting off pathogens or other recognizing even tumors in the central nervous system. And this came from a series of experiments that were done early on, where it was shown in experimental animals, if you were to do what's called a graft, take a tissue from a foreign, say, mouse species or rodent species, and try to transplant that into another strain, the animals would undergo a very robust immunologic rejection of that mismatched tissue. But if you took that same graft, skin graft or allograft, and put it into the brain of the animals, those grafts could survive oftentimes for a very prolonged period of time and not be rejected. And this was the foundational knowledge that led to this concept of immune privilege, or the brain really being an organ that the immune system doesn't seem to actively survey. We now know that that's not really, although those experiments were correct, that understanding wasn't really correct, in that what we have found is that the initiation of an immune response in the brain is pretty impaired. So the brain is not a very good organ for immune responses being started. However, if you were to stimulate an immune response, say against that graft in an animal in the periphery, and then implant those grafts into the central nervous system, that immune response that was generated does in fact recognize that allograft and lead to its rejection. So we now know that the central nervous system does actually have lymphatic drainage, meaning that antigens that are in the brain can actually drain from the central nervous system and make its way to peripheral lymph nodes where the immune system can be activated. We also know that although the blood-brain barrier does prevent naive immune cells from entering the central nervous system, that activated immune cells, so activated T cells and activated lymphocytes and effector cells, they actually do cross the blood-brain barrier. If you get an infection in the central nervous system, we would obviously need the immune system to be able to get into the brain and protect us against viral infections. Oftentimes, in fact, that immune response can be potent enough or inflammatory enough that it causes problems in the brain. But activated immune cells can get into the central nervous system. And we also know that the blood-brain barrier in many invasive tumors, at least in certain parts, is disrupted and not quite as intact as a normal brain's blood-brain barrier. And so that also increases the access into the tumor microenvironment from macromolecules and cells in the periphery. And so the immune system can survey the central nervous system compartment, and one of the challenges is, can we induce an effective enough immune response to be effective in combating cancer? This is a graph that really shows our current simplified understanding of what's called the cancer immunity cycle, or how does the immune system really lead to a tumor rejection. And so the first step of this cycle requires that there are antigens that are expressed in these tumors. These can be mutated proteins, so that in the process of developing a cancer, you can undergo many mutations, and that can lead to amino acid changes in those proteins that make them essentially now foreign proteins expressed in those tumor cells. Or they can be overexpressed proteins that are normally not expressed in other tissues, but become re-expressed in cancer due to the dysregulated growth pattern in those tumors. Either way, these antigens have to get released from tumor cells and make their way to these dendritic cells that I mentioned earlier. These cells' job really is to capture these antigens, and if they have the appropriate inflammatory signals, they will migrate to the lymph nodes, where they essentially talk to the T cell lymphocytes and instruct those T cells that they have encountered something in the periphery that looks abnormal. It's captured those antigens from whatever that was, whether it was an infection or in this case tumor cells, and will literally instruct the appropriate T cells to become activated, to expand in number, and to leave the lymph nodes and circulate back out into the periphery in search of cells that carry those same antigens or those same proteins. And if this process occurs correctly, these T cells will survey the peripheral compartment, and when they encounter tumor cells that are expressing the same antigens that they were instructed to attack, they will specifically lead to the killing of those cells, and could literally leave a normal cell right next to it completely unharmed. So that is the specificity and the potential of the immune response to mediate the elimination of a cancer cell. And with infections, this actually works quite exquisitely well. But obviously, in a patient with cancer, one or more of these steps has been either interrupted, prevented, or suppressed, such that this cycle really is not occurring. If these cells kill tumor cells, that leads to the release of more antigen, more inflammation, and basically feeds forward into this continuous process. So really, the goal of cancer immunotherapy, the whole field, is to intervene at one or more of these steps with some modality that tries to make this cycle go forward instead of be arrested at whatever stage it happens to be halted at. And I'll talk a little bit about the different ways that we are attempting to do that in the field. But if you think of it simplistically, cancer immunotherapy is essentially trying to make this immunity cycle effective. And the studying in the field is to try to understand what is going wrong at each one of these steps and how can we intervene to make the immune system more productive in that environment. Today there are lots of different approaches. So cancer immunotherapy doesn't describe a single approach to treating cancer, but you can largely think of 4 categories where we now have FDA-approved treatments using the immune system to tackle one or more advanced cancers. The first area that has had the most study to date has been in the area called cancer vaccines. The idea behind a cancer vaccine is that we try to identify some component of the tumor cell that we know is foreign or that the immune system could potentially react against, and we create that antigen in some formulation that's administered back to the patient, usually as an injection. And this is very much similar to the vaccines that we all received as a child, and the tetanus boosters that you all are supposed to get every 10 years, that everybody does, right? No. And essentially the hope is that by inducing that productive immune response, you now can generate an effective immune activation and a memory response against those cancer antigens. The second category of treatment is an area called adoptive cellular therapy. This attempts to bypass the activating the immune system in the patient, and the concept behind cancer immunotherapy is to harvest the immune cells of the patient, activate them outside the patient's body against their own cancer, and then expand those T cells typically to very large numbers outside the patient's body and actually return those activated T cells back to the patient, with the hope that now that you've initiated the whole process, they can seek out the tumor cells and lead to their destruction. So it's a little bit more involved, but bypasses some of the inhibitory steps in the patient's body itself. The third category, which has been the most recent development, but probably has had the largest expansion in terms of new treatments for cancers, involves drugs called immune checkpoint inhibitors. This, quite simply, has come from our understanding that while we've known for a long time about some of the signals that lead to stimulating the immune response or turning it on, if you think about it, it makes sense that there are also signals that turn off the immune response, because if you couldn't shut down an immune response, say against an infection or something else, that would lead to pathology, and so we have pretty tight regulatory mechanisms to dial down an immune response at the appropriate time. Well, it turns out that in many patients with cancer, these stop signals are essentially on all the time, and so the immune system is essentially receiving a signal to halt instead of go and attack against those cancers. And by developing drugs that essentially block those inhibitory signals, essentially turning the red light back to green, the immune system can now proceed in a much more rigorous fashion. And in some cases, just that blocking those stop signals can really lead to a dramatic regression of established cancers. So we've seen a number of diseases now receive new FDA-approved treatments using these immune checkpoint inhibitors. And the last category, which is in some ways feeds back into what William Coley was attempting to do in the late 1800s. This involves taking modified viruses that are modified in such a way that they only infect the tumor cells. And when these viruses infect the tumor cells and spread, part of that process is they lead to the killing of those tumor cells as they spread from one cell to another. And what people have found is in the course of this viral infection proceeding in tumors, called oncolytic viruses, because they lyse the tumor cell as they spread, this also stimulates a pretty potent immune response, probably largely due to the fact that our body is pretty good at picking up on viruses. And that immune response not only can be directed against the virus, but now can also start to attack the tumor cells. And so the use of these modified viruses has been a recent development in the field, and we've seen some FDA-approved treatments now for melanoma using these types of viruses, and a lot of exploration of testing them in other cancer types, including brain cancers. So I'll talk to you a little bit about the approaches that we're pursuing at the University of Florida, some of those. And in the first category of vaccines, we began many years ago with this understanding that dendritic cells are the cells responsible for turning on the immune response in patients. We harvest these dendritic cells actually from patients, basically through a large volume blood draw. We somewhat purify them in culture. And then what we have done is taken messenger RNAs, which are the transcripts that encode for the proteins that are expressed in a tumor cell, and we will actually use mRNA loaded into the patient's own dendritic cells, where now these messenger RNAs encode for proteins that we want to attack in that patient's cancer. And what these dendritic cells will do is they will translate this RNA into protein, and then they will do what they are designed to do, which is to digest those proteins and present them on their surface, waiting to talk to immune cells to attack any other cell that's expressing that protein. And so when we return these dendritic cells back to the patient, we inject them under their skin. Those dendritic cells migrate to the lymph nodes. They will find T cells and present the protein that they had been loaded with before injection, in this case something that's expressed in that patient's tumor. And that can lead then to the activation of T cells that can now go forward and attack that patient's own cancer. So many years ago, we began studying the effectiveness of this type of vaccine strategy in patients with glioblastoma. So these are patients with an aggressive grade 4 tumor that were receiving standard treatment. But we started clinical trials, and these initiated back when I was at Duke University. They have continued forward here at the University of Florida. But we started a small study where we took patients, they received all the standard treatments that they would normally receive, and then they were randomized to receive one of two types of vaccine formulations. Each of these patients received dendritic cells that were generated from their own blood, and they were loaded with RNA that encoded for, in this case, a very common pathogen called human cytomegalovirus. Turns out this is a viral infection that most people have, and it usually lays dormant and doesn't have any effects. But in patients with glioblastoma, this virus can become reactivated in their tumor at very low levels. And we tested whether if we boosted immunity against this indolent CMV infection, could we generate an immune response that would now kill their tumor cells. And the patients were randomized to receive either the dendritic cells loaded with this virus protein alone, or we also combined the dendritic cell vaccine with a tetanus diphtheria booster shot. And the idea, again, was that we know people carry a pretty strong recall response to this tetanus toxoid, and we tested whether or not giving this in combination with the vaccine might provide some benefit in activating these dendritic cells and generating their immune response. This is the data that looked at survival from these patients that were involved in this very small clinical trial. And you can see that the patients that received this combination of the tetanus diphtheria toxoid and the dendritic cell vaccines had a pretty significantly prolonged, what we call progression-free survival and overall survival. It was more than twice the other group. And although this was a small study, this was encouraging that perhaps that combination could be effective, and we've continued to explore that in other contexts. I'm going to switch gears a little bit and just show you a short video that highlights one of the patients who was involved in this trial. This is a patient, Sandy Hilburn, who enrolled in this study in 2006. This was a feature that was done on her in 2008, 2 years into the clinical trial. And then in 2015, they ran a follow-up story on her. And I'll see if I can get this switched over for you. It is, and then I have to, okay, I think we got it.
A promising development to report tonight in battling one of the hardest forms of cancer to treat. Every year, nearly 23,000 Americans are cancer. But now researchers have found that a simple tetanus shot might boost the chances of some patients living years longer than they expected. NBC's Stephanie Gosk explains.
Every day, Sandy Hilburn walks and walks. 9 years ago, a doctor told her she had just 2 to 3 months to live.
How many miles are you walking every day?
Nothing, just 2 to 4.
Nothing, just 2 to 4. That's a lot. 2 to 4?
It just feels good.
Her diagnosis, glioblastoma, brain cancer.
Glioblastoma is highly aggressive. It's an absolutely devastating disease and universally fatal.
But Hilburn took part in a Duke University medical trial that extended her life.
So this whole team.
These are all new.
So the grandmother of 2 can now proudly say she is a grandmother of 6. The study was small, 12 people altogether. Following standard surgery, chemotherapy, and radiation, all received a novel therapy that uses the body's own immune system. 6 were also given a dose of a well-known vaccine, the tetanus booster.
If you give a patient a boost of tetanus, it sort of puts the lymph nodes as well as the entire immune system on high alert, acting like a siren to the rest of the cells.
So when the immunotherapy is given, doctors believe the body is primed to fight the cancer cells more aggressively. The median survival rate for the 6 who received the tetanus was over 2 years. That's twice as long as the rate for patients who receive standard therapy. Hilburn's success exceeded all expectations, and she still has no sign of a tumor. Doctors say it is too early to know for sure, but they are hopeful the research could help fight other aggressive cancers as well.
I have such a good quality of life, and I am grateful for the vaccine for that.
Sandy Hilburn is the walking proof. Stephanie Gosk, NBC News, New York.
So that was done 2 years ago, and as mentioned in the report, this was the first phase of a clinical trial. For any treatment, it has to go through what we call 3 phases of development. So we are in the midst of conducting a phase 2 clinical trial. That will be done in about 120 patients. And if that looks promising and continues to show benefits, then the next stage would be a phase 3 clinical trial, and that would have to be a much larger study to really definitively demonstrate that this could potentially add benefit to patients who are receiving treatment. So it's still very early stages, but we're obviously hopeful and optimistic that perhaps this may be one approach to trying to engage the immune system. What I'm showing you here, and I'm not going to show a lot of data in 10 slides, but I just wanted to give you a understanding a little bit of what was done in this study. So our original hypothesis of giving that tetanus booster was to try to increase the number of dendritic cells that get to the lymph nodes. We knew from others' work that when you inject these cells into the skin, only a small fraction of them actually make it to the lymph nodes and activate the immune system. And so we tested whether we had a hypothesis that perhaps if you injected a tetanus booster shot, the strong immune response against that could help these cells sort of migrate better. And to try to answer that question, we actually followed those cells in patients. What you're looking at here is this is a CT scan and something called a SPECT image. And all that is that these cells were given a tiny bit of radioactivity, not enough to harm the cells, and a small fraction of the cells were actually labeled. But we could follow essentially where they were injected at the skin sites, and then at 24 and 48 hours, look at what fraction of them had actually made it to the lymph nodes. And a radiologist who was blinded to the study was able to determine where the lymph nodes were, and by measuring the amount of radioactivity that was injected plus the amount that made it to lymph nodes, you could essentially calculate the percentage of cells that had successfully migrated. And so in that study, the patients had been randomized to either receive the single vaccine alone or the combination, and then this is what that data looked like when it was unblinded, so to look at the percentage of cells that had made it to lymph nodes. And I think you could appreciate that the group that had the tetanus toxoid combination, both at 24 hours and at 48 hours, had overall greater migration than the group that had not received that at the same time. And you can see there were still some patients that didn't exhibit good migration of their cells. So that's something we're continuing to study to try to understand, why do some patients' cells seem to respond well versus others. But interestingly, there was a strong correlation between how well the cells migrated to the lymph nodes and how well those patients did. And so there's an ongoing study now that's been about enrolling for the past year now at the University of Florida, where we are exploring in 120 patients 2 different formulations of this vaccine. It will take several years before we'll have the outcome of that study, but hopefully we would ideally be able to confirm that the addition of this vaccine formulation to standard treatment may have some benefits. And this study is being done in collaboration with my colleague back at Duke University, Dr. John Sampson, who also was a collaborator on the initial studies. The next area that we've been actively exploring is an area called adoptive cell therapy. And as I mentioned to you earlier, this involves, instead of boosting the immunity directly in the patient, we essentially harvest the T cells, which are the cells you're trying to activate, and in some way generate cells that are antigen-specific outside the patient's body, stimulate those T cells, expand them to really large numbers, and then infuse them back to the patient. While this is a little bit more complex process, the potential advantage is you can generate much larger numbers of these activated killer T cells using this process than we typically can achieve with a vaccine in the patient themselves. So the process that we have used and has essentially was built on that vaccine platform, where now we take those same dendritic cells loaded with this RNA that we've isolated from the patient's tumor, but instead of just re-injecting the cells back into the patient, we now mix them with their own lymphocytes so that they can talk to each other essentially in a clinical laboratory. That's done in an environment where there's maximal stimulation stimulus provided to those cells in culture. And the hope is that would lead to an expanded, activated, tumor-specific cytotoxic T cell population. Those patients then get standard treatments, typically involving chemotherapy. And one of the things that others and we have found is that while chemotherapy does unfortunately have side effects, one of the potential benefits for immunotherapy is that when you knock down a person's own immune system with chemotherapy, but infuse these activated cells into that patient, these T cells essentially have a lot more room to expand in that patient because they're not competing with as many cells. In fact, your body is trying to recover a normal white cell count anyway, and so it is pumping out a lot more growth factors. It's trying to build its immune system back up, and we have found if you infuse these cells in that window when a patient's recovering from chemotherapy, you can even get a much more effective expansion of these activated cells. So we essentially try to take advantage of the standard treatments and figure out what's the best way to combine them with some of these new approaches of immune therapy. Those are injected intravenously, and then we boost those T cells in the patient with the same vaccines, dendritic cells we use to expand them ex vivo. So we have a number of ongoing clinical trials that are exploring this approach. What we have also found, which has been kind of interesting, in some patients, because of their standard intense treatments, they get a high enough dose of chemotherapy that they actually have to receive a stem cell transplant to recover from the chemotherapy. One of the investigators in our group named Dr. Flores has discovered that these stem cells that are oftentimes given in that scenario, in addition to rescuing the patient from the chemotherapy, they actually interact with the immune cells and make these T cells even more effective at rejecting cancer. And so we have begun to really actively explore the novel use of stem cells to enhance the immune response, even in patients that aren't receiving intensive chemotherapy, but simply using these as a way of conditioning those immune cells to fight the tumor more effectively. So that's a really active, ongoing area. I'm going to show you a couple of slides. This is now done in preclinical models of brain cancer. What you're looking at here is essentially a fluorescent cross-section of a brain and a tumor of an animal that was treated with T cells that were generated against the tumor, but the T cells were derived from a mouse that has a green fluorescent protein tag, so we can actually follow where those T cells have gone after you inject them intravenously. And what you're seeing is that what you're not seeing in the area of the black, the area that doesn't have any green T cells, this is actually normal brain, and these T cells do not infiltrate or migrate to the areas of the normal brain appreciably at all. This area is actually an area that is involved with a glioma, and I think you can see just there's a vast amount of these green T cells that have actually trafficked to the tumor site and are actually infiltrating essentially throughout the tumor. And so we have been able to show directly that T cells that are activated, and others have shown as well, when you inject them, they can actually traffic and specifically localize to areas of tumor growth, and the blood-brain barrier is not an inhibition to these immune cells finding their targets in the brain. Now, one of the questions is, are they effective, though, at treating this cancer? So what you're looking at, again, this is a preclinical, this is not clinical trial data. This is the survival of brain tumors in these preclinical models where they're given high-dose chemotherapy or high-dose conditioning, either radiation or chemotherapy, and stem cell rescue. And I think you can see there's really no survival benefit with just a standard intense treatment. If we add the infusion of T cells alone, there's also no benefit. These were cohorts that actually got dendritic cell vaccines all the way through the recovery from that intensive treatment, and there's also no benefit. But if you actually combine these together, all of a sudden we saw about a doubling in the survival of those groups and about 30 to 50% cures of these established aggressive cancers. And so this really pointed to the fact that there was some interaction, or what we would call synergy, because none of these components by themselves had any effects, but when you combine them, you get pretty potent effects. And so one of the areas of intense study in our group is to understand how are these cells essentially communicating with each other in a way that they can now give an effective immune response, where by themselves they seem to be incapable of doing that. This is also true in multiple tumor models. So that was a model of glioblastoma. This is an animal model of a very aggressive tumor called brainstem gliomas. So these are tumors that arise in a pretty critical area of the brain. And again, if you give T cells and just the vaccine, you do get some benefit in this model, but none of the animals have a long-term survival. If we add the hematopoietic stem cells in that mix, you can see you get a better survival. And so again, each of these components seem to be critically important. This is another model of a different type of common brain tumor called medulloblastoma. It's very common in children, not so much as in adults. And again, in this model, what we're showing here is the combined treatment does have a pretty significant survival benefit and some long-term cures. But if you use different subsets of stem cells, this is a group that got a particular subset of stem cells that don't seem to be effective in enhancing this effect. And if we use another subset of stem cells, you can see that these are pretty markedly effective at enhancing this effect. So one of our areas of intense study is really identifying which of these cells are most effective in fighting these different tumor types, and then adapting that to the type of treatment we bring forward into the clinic. So based on these observations in medulloblastoma, we actually did pursue a clinical trial in pediatric patients who have failed standard treatment for medulloblastoma, and unfortunately, despite intensive salvage treatments, we don't have any effective second-line treatments for this disease. And in collaboration with our head of pediatric neuro-oncology, Shri Gururangam, we started a clinical trial to explore whether adding this adoptive cell therapy treatment after standard treatments, including stem cell transplant, might have benefits in these patients. The protocol involved the patients would undergo surgery or biopsy, which is standard of care. We would take a portion of that tumor to collect the RNA so that we could educate the immune cells against the patient's own messages that are being expressed in their tumors. We would also harvest what's called a leukapheresis, the large blood, to make the dendritic cells and T cells. These patients would then go on to complete standard of care treatments, either high-dose chemotherapy and stem cell rescue, if they were candidates for that, or what's called a salvage, a little bit less intensive regimen, if they were candidates for that. And then when they completed those regimens, they then got the infusion of the expanded T cells, the dendritic cells, and those stem cells. So just like the preclinical design that I showed you previously. And then these children did not receive other treatments, but were followed clinically, radiographically, and we also do collect blood to monitor immune responses. So this is an ongoing study. We have about another year to enroll patients on the study before we'll have the data. But I'm just going to show you a response. This was a pretty remarkable responder to this treatment. This was a 21-year-old who unfortunately had a relapsed disease after receiving standard treatment about 3 years earlier. And what you're looking at is an MRI of the brain. Essentially, the normal areas of brain are kind of dark gray, but everywhere where you see this light white areas of what we call enhancement, this is actually tumor that has grown back. And this patient had a pretty aggressive relapse pattern that we call leptomeningeal disease. It means that the tumor has essentially spread and is coating almost all of the surfaces of the brain, so even in all of these areas here. And so this patient underwent standard treatment, including high-dose chemotherapy. Unfortunately, during that time, this disease continued to progress. And then when he completed that therapy, he did have the infusion of the immune cells. And this was a patient that actually ended up having a near complete radiographic and clinical response to the treatment. You can see that all those areas of white in this section of the brain are completely gone. This patient also went from, had metastatic disease to his spinal cord, to his rib cage, and to his bone marrow. Those lesions also regressed. He was able to go back to work. He had been, so had a pretty remarkable clinical response to this type of treatment. One of the things that was unfortunate in this setting was that about several months after the treatment, he began to complain of headaches, and unfortunately had a relapse of this disease in the brain. And so one of the things that we have been trying to understand, in this case, when you've induced a very effective what appears to be a very effective immunologic response, but it hasn't persisted or been durable, what are the reasons that the immune system perhaps wanes or isn't maintaining that control? And can we improve upon that and come up with better treatment regimens that prolong the duration of these responses? And so, the reason I point these examples out is because oftentimes people hear about remarkable new treatments and the breakthroughs, but the process that it really takes to get there and really have something that can be effective for the majority of people is really an ongoing and intensive process of research and going back from the clinic, back to the lab to try to gain better understanding, come up with better approaches, and bring them back forward. And eventually, I do believe, and there's many examples, we do find treatments that are very effective and hopefully can be an impact for the majority of patients, but it is a process that takes some time. This is just another example of area that was intensely involved with tumor, and again, complete clearing of that disease. So how can we think about perhaps how to keep the immune system on longer? I mentioned to you these immune checkpoint inhibitors, and this has been, these are essentially the stop signals that turn off the immune response. And one of the exciting areas as we've begun to learn what these signals are is if we can block those off signals, perhaps we can keep the immune system on much longer. And so this is just a diagram that shows the number of checkpoints that have actually been identified, and the list is actually longer than this. So as we learn more and more about which of these signals turn off the immune response, we can develop antibodies that block these signals. We're also learning more and more about signals that keep the immune response on, and we can develop antibodies or drugs that boost these signals. And so one of the exciting areas for future development is to now combine some of these approaches where we, use a vaccine or use an adoptive cell therapy in combination with a checkpoint inhibitor or in combination with what's called an agonist antibody to turn on the immune response. So I mentioned to you some of the challenges that we're facing, and this is a simplified diagram that kind of shows you what does immune therapy really look like right now for patients. What we're seeing is that with standard therapies or targeted therapies, sometimes we can see patients that respond, but the responses don't last as long as we would like. And there are examples in immune therapy where there appear to be these subset of patients that do have both significant and prolonged durable responses, but the goal is to try to figure out what's happening for these that don't seem to respond, and can we keep moving this curve further and further upwards. So the areas of intensive study in immune therapy are really how to expand what sometimes is 20 to 30% of patients that seem to be generating real significant benefits in some contexts, and to improve that by understanding what the differences are. A lot of that is from understanding that the tumor is really a complex microenvironment, and as we learn more about all the different cell types that are in that environment and how they affect the immune system, we can become more effective at developing the right strategies for the right patients. So I'm going to finish with a simple concept that I think is easy to understand. What we have learned from studying the tumor microenvironment is that some tumors are what we call hot and others are what we call cold. And what we mean by that is that, there is already evidence that the immune system appears to be attempting to attack that cancer even before you've intervened. This can be because there's a lot of T cells already present in the cancer, that the cancer has a lot of mutations that the immune system seems to be able to recognize, and that there are other markers that show that there's an inflammatory response already going on in the tumor. What we have found in general is for patients that have that type of picture, what we call a hot picture, they tend to respond better to the immune interventions. But if they have the absence of these markers, they tend to not be people that seem to be responding as effectively. And so a big area of research is can we turn a cold tumor hot? Can we figure out how to induce that type of environment before we use these active immunization strategies? And so the future efforts are really focused on, identifying the most potent targets to go after, making these dendritic cells and T cells more effective, overcoming the immunosuppressive environment, and understanding what's the difference between people who respond or do not respond. So in conclusion, I think the immune system really has been able to show that you can mediate significant immune responses against advanced cancers, although right now I would say that's in subsets of responding patients. That cancer immunotherapy does show promise in the treatment of pediatric and adult brain tumors in some early phase clinical trials that are continuing to be evaluated in later stage trials. And also the future studies are really focused on effective combinations and overcoming the mechanisms of treatment resistance as we identify them. And also importantly, if we can understand which patients are more likely to respond up front, we can tailor the treatments that we deliver to those patients and perhaps direct patients to other forms of therapy that might be more effective for them. So these are the areas that our group is really intensely focused on, and as well as others in the field, and I think are beginning to and will continue to bear promise for patients with brain cancers. So lastly, I just want to acknowledge the people who conducted some of the work that I highlighted. Dr. Flores is continuing to study the role of stem cells in enhancing immune responses. Dr. Wong is our Director of Clinical Operations. She really is responsible for helping us get the observations out of the lab and into clinical trials. I mentioned Dr. Guarangan, who's a colleague of mine for many, many years and directs our pediatric neuro-oncology program and helps oversee all the trials that we're doing in the pediatric setting. And then Dr. Yugarov and Yang are research scientists in our group who really have advanced some of the techniques for understanding how these immune responses proceed in these patients and in the preclinical models. I'd also like to thank, this is the entire, well, it's at least a more recent picture of the immunotherapy program members, all of whom have contributed to the ongoing work in some fashion or another, and our funders who have supported these studies. Most importantly, the patients and really and their families who have, volunteered and subjected themselves to these clinical studies to try to advance the field certainly are very courageous, and we hope to continue to gain understanding that will benefit that population of patients. So that was actually the last slide, and I will stop there and take any questions.